Hi, today we will discuss on pharmacological management of trigeminal neuralgia. So trigeminal neuralgia, for the pharmacological management, we have initial preventive therapy, which is the mainstay of treatment, mainstay of pharmacological treatment irrespective of type of trigeminal neuralgia. We have carbamazepine and ox form of carbamazepine, which is a keto form of carbamazepine. So carbamazepine is given at a dosage of 100 to 200 mg twice daily. Then you gradually increase. How frequently we increase? 1 week or 2 weeks till we get the response in these patients. Okay. So what is the usual therapeutic dose that we will see the response in these patients? Usual therapeutic dose that gives response is 600 mg to typical maintenance doses in these patients are usually 600 mg to 800 mg per day, roughly around 300 mg twice daily or 400 mg twice daily. What is the maximum dosage that we can give in these patients? The maximum dosage that we can give in these patients is 1200 mg. So why to discuss about maximum dosage, or why to discuss about carbamazepine? When we discuss about the maximum dosage and the other things, you should know the adverse effects. So adverse effects of carbamazepine are, one is nausea, vomiting, that we all know, rash, okay, and there is also possibility of myelosuppression, which leads to aplastic anemia, okay, and also syndromes like Stevens-Johnson's syndrome, Stevens-Johnson syndrome, or drug reaction with eosinophilia and systemic symptoms. There are so many other complications as well. These are the major complications in trigeminal neuralgia when the patient takes carbamazepine. Since the Oxfam has been made to decrease the amount of complications that are usually seen with carbamazepine. The typical initial dosage of oxcarbamazepine are 150 to 300 mg twice daily. Okay. Since carbamazepine has so many side effects, oxcarbamazepine has little lesser side effects, and the dosage can be increased little early, like about 3 days. Okay. And the usual therapeutic doses that we achieve the symptoms symptomatic relief is usually same in both the cases. Okay. Maximum dose that we can give in these patients, few textbooks say 1200 mg, few say 1800 mg. 1800 mg is considered maximum dosage of oxcarbazepine that can be given in the patients. And the complications are similar in both the cases, whether you give carbamazepine or oxcarbazepine. Now we will switch to a therapy which is called as alternative therapy or add-on therapy. Why alternative therapy? Because not every patient can, these medications are suitable. So we may have to switch to other medications. Add-on therapy, medications may be suitable, but there may not be the appropriate response in these patients. So what do we have in this alternative add-on therapy? We have gabapentin, we have lamotrigine, and we have baclofen. What is the usual dosage of gabapentin that we give in these patients? It is about 100 mg to 300 mg once daily to twice daily formulations. How frequently we can increase? How frequently we can check the response in these patients? It is usually 3 days. Okay, and at what usually maintenance dose or therapeutic dose the patient sees response? It is 900 mg, and there is something called as maximum dosage. Maximum dosage that we can give in these patients is 600 mg. Okay. What are the side effects with gabapentin? Gabapentin, the patient feels drowsy, okay, or sleepiness. There is also possibility of weight gain in these patients. We have lamotrigine. Initial dosage that we give is 25 milligram. How frequently we increase the dosage? We need at least 2 weeks, because these medications cannot be increased so abruptly. We usually wait, like groups say, usually guidelines say that to wait at least 2 weeks before you increase the dosage. Okay, so you can increase to up to plus 50 mg every time. Okay, you keep on increasing until you get a maximum dosage. So there is something called as the maximum dosage of these medications depending on multiple factors. Maximum dosage is 400 mg. There is something called as drug interaction with lamotrigine, because drug interaction occurs when there are either hepatic enzyme inhibitors and hepatic enzyme inducers. If the patient is already taking carbamazepine, so carbamazepine is a hepatic enzyme inducer. So the lamotrigine will become ineffective. To make the drug ineffective, what we do is like we add it at a 3, 5, 6, 7 protocol if there is no response. In the third week, we increase it to 100 mg. In the fifth week, we increase it to 200 mg. And the sixth week, we increase it to 300 mg. And at the seventh week, we increase it to 400 mg. Maximum amount of dosage that we can give in these patients is 400 mg. Okay, like 200 mg twice daily. Then we had even inhibitors like valproate, sodium valproate. In these, the initial recommended dosage is 12.5 milligrams. Okay, they increase plus 25 in these patients, plus 25 instead of plus 50, and the maximum dosage that we reach when a patient is taking sodium valproate is 200 mg. So everything is half of what is recommended, and half is the maximum dosage, half of the increment. You got it? Now we will come to third drug in the alternative or add-on therapy is baclofen. So how do you give baclofen in these patients? We initially start with 10 mg once daily. Okay. When can we increase doses? How frequently or how far we will check for response? We will check for response every 3 days. Then we will increase the dosage. How far we can increase the dosage? We can increase up to 80 mg in divided doses. The total dosage per day is 18 mg. These all are total dosage that can be given per day in a patient. So we have discussed side effects of all the medications. Now we will discuss side effects of baclofen. Side effects of baclofen include dyspepsia, hallucinations. Patient will have different kind of hallucinations. In a patient who is already prone to seizures, these medications can cause rebound seizures. Now we'll discuss on other medications that are used in trigeminal neuralgia. Now we will discuss on other medications that have been used in trigeminal neuralgia. Other medications that have been used are trigeminal, phenytoin, tizanidine, pimozide, and quinine. Trigeminal will initially give a dosage of 25 mg once daily, gradually increased every 3 days until the pain relief is achieved with additional add-on therapy. So a typical maintenance dosage in people garden is 150 to 600 milligrams. It is not once daily kind of formulation, but it is divided in either 2 doses or a 3 divided dosage. Other medication that we have is phenytoin, also called as eptoin. The dosage for oral or IV formulations is 15 milligram per kg. The total dose is divided in 3 divided doses. For example, one patient it's 60 kgs, 60 into 15, 500, 5 6 are 30, 100, 1 6 are 6, 900 mg. So for a 60 kg male, we can give up to 900 mg in 3 divided doses, like 300 mg in the morning, in the afternoon or evening, and at night. Okay. We have tizanidine. Tizanidine is given at doses of 2 to 4 milligrams once daily. In case of extreme spasticity, the dosage has been given till 24 milligrams per day. But in case of trigeminal neuralgia, the dosing is not so clear. We have pimozide. Pimozide is given at a dosage of 2 to 12 mg once daily. Okay, but this medication has is known to cause Parkinsonism, sedation, extrapyramidal symptoms, and so many other complications. Okay, we even have tokenide. Tokenide is anti-arithmetic medication. Not usually preferred by micropatient surgeons. Now we'll come to a rescue therapy. In a patient who is having severe pain diagnosed with trigeminal neuralgia, it is important to diagnose trigeminal neuralgia. What happens is, like, we have so many patients, like other colleagues of either it is neurologist, neurosurgeon, or pain specialist, or ENT surgeon, or general surgeon, or general medicine. Any kind of facial pain, they diagnose it as trigeminal neuralgia. There are so many different forms of entities of pain that needs to proper diagnosis and differential diagnosis. So in a patient who has been diagnosed with trigeminal neuralgia, for acute rescue, one we can give for initial therapy is initially we can give a nerve block, peripheral nerve block. Okay. Meanwhile, we can even give a Botox therapy for severe pain management cases. Nerve blocks can also be supplemented with a corticosteroid add-on. Okay. Or even neurolysis techniques like absolute alcohol therapy when a patient or glycerol neurolysis, glycerol therapy. Okay. So medications, rescue therapy in these patients, when you have tried these medications, still if the patient, like initially if you were given a nerve block to this patient, you want to give a medical management for this patient until and unless you increase the dosage of all the other primary mainstay of treatment or adjunct add-on therapy. While you are increasing the medications, you can give rescue therapy with medications like sumatriptan, phenytoin, lidocaine, lacosamide. Sumatriptan, either you can give subcutaneous formulation or you can give oral formulation. Subcutaneous dosage is 3 milligrams and oral dosage is 50 milligrams. These are in once daily formulation. Phenytoin, as we discussed earlier, the dosage is 15 milligram per kg. Whether oral or IV, the medication's dosage remains same. If you are given IV, you give it slowly over at least over 50 mg for 5 minutes speed. You don't give everything at a rapid shot, everything in a 10-second kind of speed. You have lidocaine, you give it at a dosage of 5 mg per kg. Remember, lidocaine is a anti-arrhythmic drug also. So you don't give it too rapid. You give it at least over a period of 1 hour. Okay. Lacosamide, we usually start with the dosage of 25 mg and can be increased if there is no response to up to 200 milligram in these patients. Remember, a proper diagnosis of trigeminal neuralgia is important because the patient can have concomitant temporomandibular disorder, like adrenal derangement or myalgia, and even temporal headache, migraine, cervical pain, other headache like cluster headache, vascular headache, jaw pain, and other peripheral neuropathy and other kind of pain. So differential diagnosis, accurate diagnosis is more important rather than going straight forward to a single diagnosis of trigeminal neuralgia. Thank you.